My name is Sam Klempner. I'm a GI medical oncologist at Massachusetts General Hospital in Boston, Massachusetts. So the FLOT-4 trial established FLOT as a new standard of care for perioperative management of gastric and GE junction, and perhaps lower esophageal adenocarcinomas as well. There have been some issues with implementation of this more broadly, and it's an excellent question about what are the challenges with implementing FLOT in the perioperative setting. Certainly, some of us may have less experience with FLOT, which is a 3-drug regimen and associated with higher rates of cytopenias. In the original trial, there was initially some higher rates of neutropenia, including febrile neutropenia, although this can largely be mitigated with growth factors. I think with increasing experience, we do see that we can get the majority of patients who are healthy enough to be considered for FLOT in the first place through the preoperative 4 cycles of FLOT as per the FLOT-4 trial. We commonly run into issues around cytopenias, primarily the leukopenia and anemia, and to a lesser degree thrombocytopenia, although that is certainly observed. Fatigue, loss of appetite, hair loss, and neuropathy related to the oxaliplatin, most of which we would achieve with FOLFOX anyway. Most of the common strategies center around early and aggressive fluid support. Our center commonly integrates hydration on day 1 and day 2 at the time of the pump disconnect, and routine early toxicity checks around day 8 to develop strategies to mitigate subsequent side effects with cycle 2 and 3 and 4, for example. Additionally, prophylactic growth factors such as Neulasta used to prevent neutropenia have been successful in avoiding the delays and febrile neutropenia in future cycles. Because of the decreased appetite associated with more intensive chemotherapy, we often integrate nutrition quite early on. Really, I think the message that we're trying to get across is that this is a very active regimen and certainly associated with some of the best outcomes we've seen in non-metastatic gastroesophageal adenocarcinoma patients to date. And so the data is the data, and we do recognize the activity and the outcomes are excellent. So we feel obligated to give our patients the best shot at supporting them through this combination. And really, it's active, intensive, and early and frequent support. And recognize this requires a large team between dietitians, our infusion staff, our scheduling staff, the physicians, all of the providers at multiple levels to really get these patients through. But the data has borne out that even in patients who are over 65, the majority of them can be safely supported through FLOT. And it is definitely our preferred approach in the gastric and some of the GE junction patients as well. The adjuvant components of FLOT are somewhat of a different story, and it is difficult to get patients through adjuvant anything after a subtotal or total gastrectomy. And so there are increasing efforts to perhaps move more of the FLOT into the neoadjuvant setting to when patients are healthier and able to tolerate therapy a little bit better. These are interesting, attractive, and in my personal opinion, likely to not be associated with compromise to patient outcomes. But we don't have significant data to say that 6 cycles of FLOT pre-op followed by 2 post-op, as opposed to the traditional 4 pre-op and 4 post-op, is equivalent. So as of now, the current standard FLOT administration remains as per the FLOT-4 trial, which is 4 cycles preoperatively, followed by curative intent surgery and 4 adjuvant planned cycles.